So, good afternoon from me. I want to thank very much Manos Adonaianakis, Manos Brilakis, and all the top team. And the Congress is really great. So, we're talking about the recurrent anterior instability and the bipolar fixation. Doesn't work, connection, please. No disclosures, of course. So, we're talking about the bipolar fixation, which is the bank and the replicas repair together, because replicas, I think, never is an isolated procedure. It's a capsulotenados of infraspinatus and capsule together, and in French means to fill the gap from the heel sacs lesion after dislocation. And the mechanism is that it converts an intra-articular to an extra-articular lesion. A little about the heel sacs lesion is the topic that we talk here, discovered by two radiologists in 1940. And the frequency is that is present in about 80% of primary dislocations and probably about 100% of radicular dislocations. So, it's a horizontal repaction, as we all know, of the posterior superior humeral head after the contact with the glenoid rim. The definition of off-track and engaging heel sacs lesion is pretty significant and relates to glenoid track, as we're going to see later, and the opposite is the on-track lesion. The actual tools that we use is the X-rays, the apical oblique, the striker notch view. The most accurate tool to measure this lesion is a 3D reconstruction CT, and the most accurate tool to diagnose this lesion is the MRI, of course. So, how about the classifications? There are a lot in the literature. That means that none of them are too good. Usually, we use the Ivan Flatov's classification, which is related to the articular surface, with a 20 or 40%. So, Stephen Burkhardt and John de Beer in 2000, about 20 years far ago, discovered the definition of the engaging heel sacs lesion, which is a most significant risk factor of failure after our standard arthroscopic banker repair. And we can see it arthroscopically if we put the arm in a 90-90 position, and the humeral head is falling anterior to the glenoid rim. We must say that every heel sacs lesion is an engaging lesion at some point of time, but this has to do with the size of the lesions. We heard a lot about glenoid track in the last few years. This is the way that we calculated from the CT 3D reconstruction. Arthroscopically, maybe if we see that the heel sacs extends to the base of the calf or from the bare spot of the glenoid about 16 or 17 millimeters or more, for sure our standard banker repair is at risk for a new dislocation failure. So, other treatment options for this lesion is the grafting, it's big bulk allografts or so. The anterior capsular application, of course. Partial arthroplasty, such as resurfacing, but we are very skeptical to put metal in a young patient. Rotational osteotomy, to be honest, I've never seen or done this operation, and I think most of people in modern times don't. And the replacements, which introduced by Eugene Wolf in 2007 in the arthroscopic way. So the advantages is all arthroscopic. you can perform concomitant procedures such as slap or other intra-articular procedures. Because of all arthroscopic, the morbidity and complications are low than the open technique. The indications, I think this slide that I put here is level 6 or level 7 of evidence because they are still evolving. Young collision athletes and high-demand athletes are maybe a good candidate. Of course, we use it for the gates and heel sacs lesion. They are off track. And about the glenoid bone loss, for sure, lower than 20-25%. I think that the new studies that referred 13.5 are more accurate. The contraindications, of course, is the big bone loss that we perform open or arthroscopic laterals, bone block with ASA, and other interesting techniques that we saw today, like Clara's. So, clinical case scenario, a 30-year-old football player with earlier instability about 3 times, very little glenoid bone loss, and a moderate heel sacs lesion in his head. These are the physical examination intraoperatively with the load and shift. Fortunately, the sulcus sign is not obvious when we perform it in external rotation. We had worries about his rotator interval then. So, these are the surgical steps. Analytically, we used the Bitzer position. Almost always a second posterior portal to find and prepare the heel sacs lesion. Then we change the scope to the superior portal and do the localization with a needle. Standard debridement of the bursa to stimulate the healing spores with a saver, the motorized bear, even a ring curette, even a needle, or whatever we have. We place the anchors, subtle sutures, by penetrating the infra by different soft tissue position prior to completing the labral repel, because it's dangerous to perform first the labral repel for 2 reasons. One, we don't see very well, and second, because you already perform your standard labral repel and you don't want to pound or hit or put your labral repel to danger. We usually use big anchors like the 3.9 peak corkscrew, for example. It's an alternative. And always we retrieve our suture with the old school Berby, transtendon and not through the muscle. Then we prepare the labrum, we get the scope to the posterior portal, and we prepare the labrum the standard way, and finish our labral repair with 3 or 4 knotless fiber tacks. Then we change again, we put the scope again in the under superior portal, and we do the tensioning of the replicans anchors. We find lately that no subacromial exposure is necessary. We use lately the blind technique of Steve Burkhardt, with a large cannula and the sutures inside the cannula in the subacromial space. So the video. Sometimes the portals in the front are too crowded, and we're trying to solve this issue. We locate the lesion. We put, after the debridement, we put our anchors. If we used large rotator cuff anchors, I think that tapping is necessary because we're talking about hard bone with high density. Then we put the anchors in the standard fashion, and then, after we settle the sutures, we finish the replissage, we get to work to finish our labral repair in the standard fashion. And after we finish the labral repair, we check it from the under superior portal, and then step by step, we do the tensioning of our replication answers. We use the knotless answers, as we said, and always put them in the center of the lesion, maybe 3 or 5 millimeters from the articular surface, because if you put it just in the articular surface, you draped across the lesion and not tag the infra in the lesion. And I think it's a big mistake. About the literature, multiple clinical studies, most important the Boileau from 2012, which shows satisfactory results. Boileau demonstrates as a relative contraindication to perform a replissage in a very young patient or in an overhead athlete. Multiple systematic reviews shows again satisfactory results. I forgot to put in the presentation a very, very important study of George Southall from 2012, which demonstrates that if you have a minimal heel sac lesion, a flat of 1, about 15 or 20%, maybe the replissage is not mandatory to perform it along the with your standard backyard repair, and maybe it's not necessary. Thank you very much.